Good afternoon. I'm Alan Weil, Editor-in-Chief of Health Affairs. Like the prior moderator, I'll enjoy the seat for a moment. Our topic this afternoon is cancer, and we're asking, with all the progress that's been made in prevention, detection, and treatment, is the end of cancer in sight? Now, cancer is the second leading cause of death in the world after cardiovascular disease. The risk of cancer rises with age, so as countries tackle communicable diseases, maternal and infant mortality, and as life expectancies rise, cancer moves up as a cause of death. So, for example, in the United States, cancer has been the second leading cause of death for more than 75 years. And you heard earlier this morning that it's the third leading cause of death here in Abu Dhabi. We published analysis in our journal that showed that cancer was the fourth most costly condition to treat in the United States in 2013. Treatment costs were about $122 billion, ranking behind mental disorders, heart disease, which is the leading cause of death in the US, and trauma. Recent developments in cancer treatment really are astounding, and when you think about a moonshot or you think about eradicating cancer, that's probably where your imagination goes. We hear a lot these days about immunotherapies. For example, there are what are called CAR T therapies, in which a patient's own T cells are extracted, they're genetically engineered, and they're reinfused. And they can have incredibly high cure rates, but only for a few very specific cancers. And they also have some very significant side effects, including death. There are things like nanocarriers that have the potential to deliver therapeutics directly to a cancer tumor, avoiding the systemic effects of traditional chemotherapy. So that's sort of the image we have of a moonshot. But if we're going to talk about emerging therapies, we probably need to talk about the cost of those therapies as well. In the US, the average annual cost of treating cancer exceeds $100,000 per patient just for the drugs. And the new CAR T therapy I mentioned is priced at just under $500,000 for one patient. Now, we naturally focus on this exciting leading edge of cancer treatment, but reducing the burden of cancer is heavily dependent upon much more mundane activities. If you look at low-income countries, the dominant types of cancer, liver, cervical, stomach, are largely preventable through preventing and treating hepatitis when it comes to liver cancer, universal administration of the HPV vaccine for cervical cancer, and screening and treatment of H. pylori infection for stomach cancer. In higher income countries, the incidence of cancer is different, and cancer reduction is tied to reducing tobacco use, reducing obesity, increasing physical activity, improving diet, reducing alcohol consumption. These combined could cut cancer rates by as much as half. So it's easy to list these factors that put people at risk, but it's much harder to change those risk factors. Early detection of cancer is critical, and much of the observed reduction in mortality is due to advances in screening and detection. But we published a paper last year that put the monetary cost of false positive mammograms and breast cancer overdiagnosis at $4 billion a year, not to mention the associated physical and emotional harms. In prostate cancer, it's another area where there are significant concerns regarding excessive screening and excessive treatment. And we know, particularly in the United States, that patients with advanced cancer often receive care that they don't want and that provides them with no clinical benefit. We also published a paper recently showing that emerging high-tech cancer diagnostics were deployed more quickly in high-income regions than in lower-income regions. Another paper described how low-income women who successfully are treated for breast cancer often lose their jobs because their employer won't accommodate their need to take time off for treatment. The point is simply that the leading edge and the high-cost treatments may actually exacerbate some of the racial, ethnic, and income disparities that already exist when it comes to cancer mortality. So if we're going to discuss a moonshot of eradicating cancer, we need to discuss not only this leading edge of technology. We have to discuss prevention, screening, diagnosis, treatment, the social and economic systems that allocate resources to these various functions, and the clinical systems that provide care. We only have 2.5 hours, so we're not going to do justice to all of those topics, but we'll cover as much of this ground as we can. And we're going to begin with Dr. Lily Peng. Dr. Peng is a trained physician who works at Google Health. She focuses on applying deep learning and other Google technologies and expertise to medical imaging. Prior to joining Google, Lily was at Doximity and a co-founder of Nano Precision Medical, a startup developing small implantable drug delivery devices. So to begin our discussion of our second Moonshot, I'll turn it over to Dr. Lily Peng.